Hello, everybody. Good morning. It is my great pleasure to welcome you to Day 2 of the 2025 CareOregon Pregnancy and Substance Use Disorder Learning Series. This series takes place on 3 separate events, and today is the second day of our 3-day journey. Today's session focused on building cultural awareness and reducing biases and stigma. Our last session will be on April 4th, and care coordination is our theme that day. You do not have to attend all 3 days to receive CME credits, but we would love for you to come, join us, and build community. Here is the agenda for today's exciting content. We will spend all of our time here in the ballroom today, no breakout sessions. Lunch will be served around 11:45. Each day features 4 sessions, and one can earn 4 CEUs for each day attended. Maintenance of certification Part 2 credits are available for our physicians to claim, and this can be done through the same evaluation link that will be sent out to everyone at the conclusion of today's event. You will also find that link on your printed agendas and on the very last slide of the day. Your CME certificates will come from OHSU, and they will be sent out at the conclusion of the learning series, likely sometime next month or early May. So please complete the evaluations for today's event within the week. Now, I'd like to formally open Day 2 of the Pregnancy and Substance Use Disorder Learning Series. Today, we're going to be in a space together where we can learn about best practices for understanding the needs of pregnant people in the Black and African, Latinx, American Indian, and Alaskan Native communities. We're also going to start the day with a Midwives and Doulas panel that will allow us to gain a greater understanding of how to provide culturally specific and trauma-informed care to those who are pregnant and experiencing substance use. I do want to take a moment today to acknowledge that we'll be discussing some difficult topics. I want us to be mindful that we are having conversations that might bring up discomfort. Please do what you need to do to stay present and regulated. Feel free to move around, take advantage of the quiet space at the end of the hall to your left, your right, my left, and you'll see a sign for the quiet space down past the lactation space. My colleague, Marietta Gray Smith, at HealthShare taught me a mnemonic that I think is so valuable for our time here together. We have been given our heads, our hearts, and our hands. Our heads can sort through the information we receive, our hearts can filter through that information and tell us how we feel about it, and our hands create our actions in the way that we use this information. I ask you to please maintain a psychologically safe environment for our presenters and panelists today. Before asking questions or making responses, please think about the way you would like to receive your question if it were asked to you. And please ensure that you are discerning if your questions are coming from a place of curiosity and growth rather than a place of personal need. We must all be responsible and accountable with our words and our actions. I invite you all to create and exist in a safe space together here as we learn. According to the Treatment Improvement Protocol 59, published by SAMHSA, cultural competence refers to the ability to honor and respect the beliefs, languages, interpersonal styles, and behaviors of all individuals and families receiving services, as well as staff who are providing such services. Cultural competence is dynamic, it's ongoing, and it's a developmental process that requires a long-term commitment and is achieved over time. This is the continuum of cultural competence, and it can apply to both individuals and organizations. At one end is cultural destructiveness, and this is when organizations and individuals completely negate the relevance of culture in the delivery of services. The expectation is for clients and patients to fit into the treatment program without providing culturally congruent care. This can be damaging. This can create an environment for an individual that is against healing. And the belief behind cultural destructiveness is the attitude that mainstream culture and current practice are superior to other approaches. Cultural incapacity refers to the expectations for clients of diverse backgrounds to conform to services, and it provides clients little autonomy during treatment, planning, and providing services. Cultural blindness is based on the belief and assumption that all cultural groups are alike and have similar experiences. They try to make the treatment approach fit everyone, and approaching clients as individual would mean that they didn't have to address the need and focus on cultural competence. Cultural pre-competence is kind of similar to the pre-contemplation stage of change. It involves developing a basic understanding and appreciation of the importance of sociocultural factors in the delivery of care. Organizations and individuals at this level may be exploring steps toward creating more culturally responsive services. There's acknowledgement that more information and training are needed, but they may not know how to implement the system and behavioral changes needed to make those culturally proficient services. Finally, where we hope everyone will arrive and remain for the duration of their journey, is cultural competence and proficiency. This is all about being aware of the importance of integrated services that are congruent with diverse populations. There's an active commitment to learning, engaging in self-assessment, and identifying a plan to implement cultural competency. In organizations, it looks like an ongoing commitment to workforce development, training, evaluation, development of services, and evaluation and improvement. In individuals, it looks like an acknowledgement of significant differences across and within races, ethnicities, and cultural groups. The understanding that there are differences that need to be integrated from assessment to treatment planning to services to discharge. For both, it is a commitment to ongoing learning and growing. Cultural awareness is the first step toward becoming culturally competent. This means gaining understanding of your own cultural beliefs and experiences and how they've impacted your life. Intersectionality is a term that was created by civil rights scholar and activist Kimberly Crenshaw. This term highlights intragroup differences and describes the phenomenon of multiple identities that shape people's experiences. The people within one cultural group or identity are not homogeneous in their expressions or their experiences, and the belonging to several other groups of identities can shape the way people navigate and see the world. For example, Noah, who is a multiracial 24-year-old who is gay and cisgender male from New York, who uses methamphetamine, is going to have a very different worldview, very different experiences, and experience stigma very differently than Mary, a white 74-year-old straight transgender woman from Kansas who uses alcohol. I want us to keep this concept of intersectionality in mind as we consider the stigma and experiences that pregnant or postpartum people of color who experience substance use disorders face. SAMHSA states that culturally responsive services will likely provide a greater sense of safety from the client's perspective, and it supports the belief that culture is essential to healing. Implementing culturally responsive services is likely to increase access to care, improve assessment, treatment planning, and placement. It reminds us that providers and caregivers that culture shapes our worldview, and this can include our beliefs and our perspectives around seeking help and using substances, and what our ideas about support and health really mean. In considering how culture impacts somebody's worldview and their treatment needs, the following need to be considered. Ensuring that screening methods can accurately and inclusively identify the needs of those from diverse backgrounds. When getting information, know what pace you need to go. Rapid fire questioning versus slowly developing that relationship and gaining that information and that trust over time. Think about your approach. Do you tend to approach clients and patients informally or very formally? Do you tend to come in as the expert in the room or as a co-collaborator? How are the dynamics of the space that you operate in? Are you behind a desk? How is your body posture and your eye contact? Each culture has a different concept of what healing is and how to get there, and this is important to explore with them. Family might look very different. Maybe like somebody's immediate nuclear family versus their extended family with in-laws, brothers and sisters. Some consider their family those related by blood, by marriage, or just shared identity. What treatment modalities you're using are important. Do they place a higher value on cognition than emotions, or vice versa? Do they involve movement, being in nature? And two very important ones that I want us to think through are building trust and ensuring that language is accessible. Without these two pillars, it is extremely challenging, if even possible, to move forward with a therapeutic alliance or treatment. Moving forward, some things to keep in mind are to cultivate a willingness to explore your own culture that has shaped your belief and experiences. Have conversations with those who have different identities or experiences than you do. Know that being culturally proficient and competent is a marathon with no finish line. People and culture change, we change, and we must be willing to make space for those changes. Have humility, be willing to understand and ask for guidance. Now, I would like to bring up our panel of experts to discuss how midwives and doulas can improve health outcomes by providing culturally proficient and trauma-informed care. Welcome, panelists. right, panelists, please introduce yourself, your roles and organizations, and how this work found you.
Good morning. I'm Desha Reed-Holden. I am a doula, a lactation counselor, a car seat technician, and a staff member with Multnomah County's Healthy Birth Initiatives program. I always had a love and curiosity about pregnancy and reproductive health, and the more that I learned about my family's origin stories and the lack of support that my parents had, I just realized that babies are cool, but parents are really where it's at. And so that is my love, is just supporting parents.
Hi everyone, good morning. My name is Chelsie Porter. I use she, her pronouns. I am from Seattle, and I'm a harm reduction doula up in Seattle. I actually came to doula work kind of through a back door. I worked in syringe exchanges and doing outreach with folks who use drugs for about 10 years before I interned at a place called Open Arms Perinatal Services in Seattle that provides community doulas for folks, and really fell in love with birth work and realized how few resources there are to support people who are pregnant and parenting who also use drugs, who might be living outside. And my two loves came together, and here I am today. Thanks for having me.
Hi. My name is Katie Wright. I'm a certified nurse midwife. I work over at Legacy Emmanuel. I've been a midwife for 13 years now, and I've been over at Emmanuel for just starting 9 years. I am the clinical lead for Project Nurture over there. And I think really similar to what Desha said, I thought I grew up around obstetrical, and like my mom was an OBGYN, so I kind of grew up around that, but I always thought, yeah, babies are okay, but parents are where it's at. So that's kind of where I came into this, and just found Project Nurture when I started with Legacy and realized that this was just a big calling of mine.
So how would you say that you specifically support people with substance use and mental health diagnoses?
As a doula, and even as a lactation counselor, I really take the approach of treating mental health disorders and substance use disorders as the realm of cultural competence. So there is a culture around substance use disorder that we have to acknowledge. And so the way that I support families is really getting down to the root of building trust, understanding what their goals are, understanding how I can support them, keeping custody of their children, because I do prioritize serving Black families, and so that we are more heavily targeted and overrepresented when it comes to child welfare involvement everywhere, but we know that that's specifically true here in Oregon as well. And so for me, really get into the root of what it means, what kind of support they're looking for from me, and then using my relationships in community and through the systems to be able to bring in those additional supports for families. And then being prepared for what their birthing experience is going to look like, and preparing them for that process as well, and understanding we may encounter hospital staff that have an immediate distrust of your ability to care for your baby. And so being preparing them, and that being a part of putting together their birth plan as it is, to be able to navigate that in an emotionally healthy way as much as we can, and creating a culture of safety for them.
Yeah, like I mentioned, I came to this work from harm reduction and from working in needle exchanges, and so the type of harm reduction doula support that I provide is very focused on working with folks who are actively using substances. Many of the families that I work with eventually do get into treatment and reach their recovery goals, but many folks are still actively using, and so there are some very tangible supplies and supports and services I think that folks who are using substances when they're pregnant and parenting need. I provide harm reduction supplies, everything from sterile syringes, pipes, naloxone, Plan B, whatever folks need in that realm. We work a lot, as Desha mentioned, with DCYF and with care providers to really make sure that folks have advocates by their side who understand their story, who have the context of their lives, and really just make sure that they feel well supported in their path. So the process is not that different for folks who use drugs and folks who use substances, but I do think really understanding the tools they need, the services they need, and the care providers in their community that are safe for them to access and having partnerships with them is really, really important.
With Project Nurture, we see people through the pregnancy and then also for a year postpartum. And so part of that is just making sure that the door is open so that they can access care, whenever through that process that they may need to or they may feel comfortable. The door is not always open for people, so making sure that they always have that ability to reach out. I think that is just so important. And I think we all know that there is a lot of dual diagnosis when it comes to substance use disorder and mental health concerns. And there's also so much trauma that has come up for people through their lives. And so I think it's really important to address how that may interact with not only their pregnancy, how they are feeling physically in their bodies with this, emotionally, what things are coming up for them and what things are concerning in the moment. And then again, looking forward into birth and postpartum, to thinking about how these things might affect them. So I think in terms of how do I specifically support people, one is, like I said, leaving the door open, making sure that they become integrated with our team. There's no way that I could do any of this alone. We have such an amazing team when it comes to peers, CADCs, our social worker. It's just, it takes so many people to know what to access. And so, a big part of my job is making sure that patients feel safe in being able to talk about whatever it is might be their main concern right now, and then helping them to access the care that they deserve through that.
I'll have you introduce yourself. So Telia, would you like to introduce yourself, your role, organizations, and how this work found you?
I'm Telia Anderson. I am CRMII. I'm not about to drag you guys through my resume, because it's pretty extensive. All the way back to the CRMII curriculum and testing. I helped build that. I've been in this work for 10 years. Gosh, agencies. I love the fact that you said plural, because there is agencies. One, I put mine at the forefront. I own an agency called Yasin's Love. We are a culturally specific full spectrum doula program. We have different supports in place, harm reduction, Plan B pills, you name it. And we also support families in their postpartum period. There's a lot of expansion going on with my org right now, and I'm really excited about that. But yeah, you can actually Google me. It's pretty dope. LifeWorks Northwest, I see some of my staff and people that I work with in here. I'm a CRM supervisor over at LifeWorks Northwest, a culturally specific CRM supervisor, which is one of the reasons why I was a little bit late. I was supervising someone. I'm currently the president of DONA International. The list goes on and on. But let me just make it really simple. I'm an addict that's in recovery. And that's what brought me here. I never really cared about the alphabet soup. It just came with me. I had to get them because y'all said I needed to do them to do the work. And that's the only reason why I got them. I will have in September 13 years of sobriety. Well, I would like to just sum it up and say that one thing brought me here, but I'm gonna tell you the truth, guys. I did not want to do this work. It called me. Dr. Julia Vance, who was one of the original founding doctors of Project Nurture. Josh knows who I'm talking about. A couple of people in the room know who I'm speaking of. Julia Vance, she's really amazing. She was over the midwifery program up at OHSU. She bugged the crap out of me, you guys. We shared offices. She kept telling me, she was like, you need to be a doula. I was like, I don't even know what it is, and I don't want to do it. And she was like, Telia, you sit in a centering group, you teach childbirth education, and you've never took any training. You have it in your head, it's in there. Just share it with other people. And I was like, I'm not doing that. And my truth was, I didn't want to see nobody else's vagina. I didn't. And that was rooted in my own sexual trauma. I'm gonna be honest. I felt uncomfortable in that space. And I did not want to be there. I sat in that centering group and I continued to hear them trauma stories of the women and their experience in the hospital. And I was like, oh. You know, the mom in me was like, okay, all right, where do I sign up? So that's what caught it. I went kicking and screaming. I need to tell you, I took several trainings. Mother Tree, Mama Shafia, they all know me. I took all their trainings. Cornerstone, I was not fully persuaded, let me say that. I needed to make sure that this is the work that I wanted to do. And that's what caught me here. Between that and being able to identify with a suffering addict and being treated differently because I made bad choices, I didn't agree with that. And I was willing to stand in the space, that's all. Wasn't nothing spectacular.
Well, Telia, and I'll ask you, how do you support those with substance use and mental health diagnoses?
That's a loaded question. How do you specifically support? According to their needs. I always say a strength-based approach, right? I don't go into every situation looking at them like, oh, you use meth, this'll work for you. Oh, you use coke, this'll work for you. No, I always come from a space, I heard Katie say it, it's a lot of trauma. That's one of the things that I ask on my intake is, do you have any trauma? Immediately, I ask them that. I know that if you've used, like I said, live life experience, I'm not judging anybody. If you've used or you have participated in any of those ways, then there's definitely some type of mental health, if it's nothing but PTSD, right? And so I always come from that aspect. I've had people look at me and tell me flat-footed that they don't have any trauma and everything is fine and they just use drugs. And then they get pregnant and that baby starts moving around and doing different things with their body and they realize they have trauma. So that is where I come from. I don't even come from the mental health and addiction part. That's the end result, you guys. The root of where it is where I come from. I want to talk to you about your childhood. I want to talk to you about whatever you want to talk to me about that may have set you on this path. I want this to be a safe space for you to open up, and I'll help close you up. I'm not going to leave you out of here, let you walk out of here bleeding, you know, after you've shared all of your trauma. How can we fix that? How can we heal those wounds? What do we need? What approach? Because if I just come from your mental health and addiction, I'm just giving you a Band-Aid. I'm just giving you something to quiet you up long enough to get you out my face, right? I want you to heal, though. I want you to heal so you can go home and heal your family, because that's what I need in my community. I'm tired of seeing. I'm tired of burying us. I'm tired of seeing us die. I don't have any more fight when it comes to, you know, because there's an unspoken, competition within the doula world, right? I need to be here, I need to be there. I really don't give a shit, you guys. People are dying. Not, they might be dying. They're dying. Period. That's all I care about, is saving our people. It's not a distant thing. It's on our front step. It's in our homes. And so that's what matters to me.
See, how do you all support partners who are also experiencing substance use or mental health challenges?
So when it comes to engaging partners, I love engaging dads. I love engaging partners. And so for me, that work looks like, independent of our birthing person, independent of our mom, as a doula, building a relationship with that partner, building a relationship with that dad if he's interested. And so it can be one-on-one communication, it can be group communication with them together, and figuring out what it is that they need to feel comfortable and competent about caring for their baby, what kind of support they need in terms of having their social needs met, and then connecting them with resources as well, connecting them, particularly for dads, connecting them with male-centered resources that are going to be supportive for them, because a lot of the work that is available for families is more female-centered. And so finding those cultural groups for them that are more male-centered is a huge priority for me. And so building a rapport with them, building a relationship with them, building a relationship with the people that they have relationships with, and then meeting their goals and helping them to meet their goals around safety, healthy communication with their partners, and empowering them in the space of being a parent as well is a huge part of the work that I do when it comes to supporting partners and fathers who have mental health and substance use disorders.
I love this question because so often when you're working with folks who have substance use disorder or have mental health concerns, they're treated like their partner is like the blockade to their success. They're treated like their partner is actually the issue in their situation. And you know, I had a doctor one time say to me, how do we convince our patients to leave their partners to go to treatment? And I was like, not our job. That is not our job. And there are so many ways that the systems, whether, you know, in Washington State, when people go in for a 5-day compassion stay when they're in the hospital, they can receive methadone or bup while they're there, Suboxone, but their partners can't. And so partners have to leave the hospital every day, maybe the same here, to dose at the methadone clinic and then come back to their baby. If somebody goes to inpatient treatment, their partners so often can't go with them. And so I think it's both advocating for these systems that split family units and often treat people who use drugs as if their communities need to be separated for them to recover, and working against those systems and advocating for families to be kept together while also finding, like you said, these really specific supports and systems that parents and dads and partners need to also stay involved in their care and in their community as they go through treatment as well.
I would say that in my role, I typically work more with the pregnant and parenting patients. And so just because we do have one, we have kind of a closed access group, and two, just because of my, my designation, my role as a certified nurse midwife, I don't typically treat partners in the same way. However, you know, the big thing that we want to make sure of is that people feel that they have the tools in order to have safe relationships and to advocate for, you know, what they need and what their family unit needs. And so absolutely, I hear that a lot as far as like, what can we, you know, how do we separate the partner who may still be using from somebody who is in recovery? And that's not necessarily the case, right? What we want is for that family unit to be able to grow and heal together. And so I would say that our peers do absolutely amazing work at trying to help the family unit and trying to help partners connect with appropriate places for them to either be inpatient or for them to access care in a way that, specifically our Project Nurture group might not be able to help them with.
I always engage the partner by asking them what are their plans, hopes, and fears. You'd be surprised what a lot of partners are dealing with. And so I always engage them in that way. What are their concerns? What is it that they've never been able to ask? They're excluded of a lot of things, a lot of conversations happen while they're in the room as if they don't exist. And so when they come into my space, my office is family friendly and inclusive. And jokingly, I'll say this because one of my clients, and I have trauma-informed furniture. But so other partners, I always ask them what has been their biggest fear about being a parent. Sometimes that comes out in different ways. That's why you see them hovering over partners and answering questions. They don't want you to do anything, and don't do anything to her body without asking me. And a lot of times we take that as a sign that there may be domestic violence, but that may be their own trauma, trying to protect their partner. And so sometimes we can mishandle them, thinking that they are being a certain way when really they might be just being overprotective. I say that because I just include them in conversation. When I'm doing the intake, I ask my client who I'm supporting the intake questions, but I always ask the partner, I tell the partner they can chime in at any moment and give me their input or feedback, because I want to hear what they have to say. Now, will I write every little thing down that they say? No, but I'll let them know. That's the foundation of building a safe space with that partner. Having that conversation, acting like you cared, engaging them, and they will talk a little bit more, and they will be a little bit more supportive. I'll say this and be quiet. I had a couple that through breastfeeding, he didn't want his partner breastfeeding. It made him uncomfortable. What it boiled down to was sexual trauma for him. I explained to him why it was important for her to feed that baby with her body and tried to get him to engage in a different way. At the end of it all, he totally understood it and supported it, but it took a lot of giving him information. He needed to know why, what, who, when. And in most cases, we might get overwhelmed and be like, why do you care? It's not your body, right? But he just wanted to feel safe. He wanted to feel included. How can I help her breastfeed? I taught him how to store her milk. He wanted to be included. He didn't want it to seem like the baby was just feeding from her and he didn't get to bond. And so sometimes just showing them where they can get in at.
How do you encourage or incorporate harm reduction approaches into your work?
So one of the biggest things that they teach us as doulas is maintaining your current list of services available in your community and always building relationships in community with people so that you have the most current information to give to your clients. And so for me, because harm reduction is not an immediate part of my background, I have done the intentional work and continue to do the intentional work of staying in community with people who do prioritize this work and specialize in this work in a way that allows me to make sure that I can give warm handoffs to my clients and to their families. And so knowing where to get naloxone from, or whether it's for them or whether they're asking for someone else that they may be in relationship with, knowing where they can go for treatment, knowing where the child and family advocates are who's going to advocate for them to be able to keep their children with them while they go through treatment. Things like that are my responsibility, or what I see as my responsibility as a doula when it comes to harm reduction. And so keeping information on hand for our families is like the biggest way for me, but I'm also always being observant, we're asking questions in a way that seems like, to be perfectly honest, a conversation. I may have a mental checklist of things that I want to cover with a family or with a client just because, you know, based on intake or based on some of the things that we've been talking about. But the way that I'm going to go about it, I'm going to be intentional about not making it feel threatening. They're not going to be aware of the fact that I have an agenda, not necessarily to harm them or to collect information in a way that to build a case or anything like that, but also sometimes because I don't know it all, I have to get certain pieces of information so that I can take it back and talk to people who know a whole lot more than I do so that I can create a plan for how I'm going to support this family. And so really building that relationship and maintaining that effective communication so that I can get the information that I need so that I can come back with the resources that I won't necessarily have just in my own strength and my own knowledge to support them is how I approach harm reduction with my families.
As harm reduction doulas, we often say that we throw scope out of the window. Scope is big practice in doula work. If anybody, for the birth workers here, we all know. And so often we find that that scope does not apply to the families that I work with. 2 prenatal visits, labor and delivery, 2 postpartum visits is just not realistic. And oftentimes we find that we're working with folks, you know, maybe for a year before they actually get pregnant and have a baby, or maybe you meet them day of in labor and delivery and you're forming that relationship right now. Maybe you work with someone for a little bit postpartum before you stop hearing from them, or maybe you work with them for a full year because you know the overdose risk for folks who use drugs increased substantially after 6 months in the postpartum period. So I think there are lots of ways, whether you give people rides, which is a no-no in a lot of circles, you meet people in their tents, you bring them harm reduction supplies, you bring them cigarettes, other tobacco products. Like, these are all things that I think we can incorporate that's outside of a typical doula scope if you really listen to what folks need, like Telia was saying. There are lots of specific strategies, of course, when you really understand somebody's drug use, the way that you can keep them safer, whether that's helping them understand how to use less, use differently, make sure they have naloxone, make sure their families have naloxone. There's lots of specific tools and strategies that folks really need and often don't get in that setting, because when you're pregnant and using substances, very often people don't want to engage with you around that in a way that's like open and honest and actually addresses the needs you have as a drug user who's also growing a baby or parenting. And the last thing I would say is maybe not as tangible, but I think to be someone who incorporates harm reduction when you're working with pregnant and parenting folks is to really loudly and honestly believe and to share that, like, folks who use drugs love their kids. People who use drugs can be great and safe parents just like anyone else with the right support. And so often they don't get to hear that. So telling people that they're loved, telling people that you know they're a good parent.
So in terms of harm reduction, I mean, I would say absolutely 100%. You have to make sure that people know that they are inherently good people, and that they are doing the best that they can in this particular moment, in this particular set of circumstances. And again, I think it's always about meeting people right where they are. I have to say, one of my biggest pet peeves when I look through somebody's medical records and I see that they have had like an ED, an emergency room visit or something, and it says under methamphetamine use, told patient to stop using drugs. Awesome, that's great. How did that go? You know, or if somebody is going through these major life changes and these drastic steps that are happening in their life, and yet they continue to smoke, to use tobacco, and you know, and somebody's like, well, we really have to make sure that stops. We really have to focus in on that. Maybe is that where they are at? You know, I think it's really important to make sure that that you are counseling the patient about what is going on today, right now for them. We're not just talking about like, okay, let's talk about what it looks like when you've had, you know, 3 months sober and, you know, things you're in your own place and da, da, da. No, we're talking about right now. What are the things that are affecting you today? And so for me, when I do prenatal care with patients who are using substances, I do ask these questions. really straightforward. There's no judgment around it. I just want to know what's going on in your day-to-day. How are you using? What are you using? Who are you using with? What safety protocols do you have around you? And also, do you know how these things may affect pregnancy, not in terms of a scare tactic, but in terms of hey, if you are experiencing this or this or this, these are things I want you to call me about. These are things I want you to come in out. I don't want you to just sit at home and be afraid or not know that these things might correlate. I want you to know that you have a safe place to come to get that care, and that these are the specific things that substance may or may not, be contributing to. It's not about saying, stop. That's not gonna happen. You really need to give somebody the tools and the safe space to be able to, to talk about where they are today.
I will start by saying addiction is a disease, not a moral deficiency. And when we come from that aspect, you wouldn't judge or misjudge or mishandle somebody that was suffering from cancer, right? So why do it to an addict? And so that is the harm reduction lens I have. At my organization, it's a QR code, and people can come in and scan that QR code and anonymously ask for harm reduction supplies. The reason why I made it like that, I work with Black, Brown, and Indigenous people. There's a stigma in our community about certain drugs, and certain people do not like to ask about how to have safe use supplies, wound care supplies, sharps containers. A lot of our community, I've had a few of my moms come in and ask for safe use supplies. And they always, you can tell the hesitation. I had one, she was like, I just want to make sure that this is not, I said, you don't have to worry about me saying anything. Do you need one or two? I just want you to be safe. Because the end result of them using bad supplies could be endocarditis. These is long-term underlying effects that can happen on top of the addiction that can take them out quicker. And so if I can help in any way, that is, harm reduction is just giving them their options. If you stop using meth and all you do is smoke weed, I'm not going to be sitting up telling you, well, you're getting your baby high when you breastfeed. No, that's not it. I will tell them the information that is available, the evidence-based information around breastfeeding while using marijuana. I will give them that information, and they can do whatever they want to do with that. But at the end of the day, I'm trying to figure out how to support this person to continue to breastfeed the best way they know how, whatever that looks like. That's why I said nothing is carbon copy. Everything is according to that person. And I think that's the biggest part of the harm reduction approach. Just because they might not want Narcan. They might not. I offer it. I don't assume, I don't make assumptions that they want this. I don't offer automatically when someone comes into my space and they just deliver, would you like a Plan B pill? Because guess what that implies, But they know that if they want it, it's a QR code in the office, and they know that they'll scan it, I'll get the alert, I'll fill the order, and I will set it out for them. They can come and pick it up. Just that simple, no questions asked.
How do you incorporate someone's values, identity, and culture into their birth plans?
That's a good question.
I asked them. That's the easiest way, right? We're having a conversation. And so when I meet families, wherever we're meeting, whether we're meeting in their home, whether we're meeting in a public space for the first time, or at a healthcare provider's meeting or in the waiting area, I always make myself available to answer any questions that they want to know about me personally or professionally. I don't have a problem talking about anything that I've experienced. I don't lead with my education. If they want to know about that, they can absolutely know about that. But I ask them what their values are. I ask them about their families. I ask them about their relationships with their parents and what kind of relationships they hope to have with their kids. I ask them about their relationships with their partners and their friends, and if they have goals for improvement around that. And we use those things to shape their birth plans around deciding who's going to be there at the birth, who they would hope to be there but may not actually show up, and how we're going to handle the disappointment if they don't come. I ask them about, what kind of provider they have and how they feel about their provider. I ask them, how they feel about the nurses. And this in the birth plan, just because we know that birth is so fluid, we're preparing throughout our time together for that birth plan to possibly fluctuate. And it doesn't just fluctuate based on the need of medical care, it fluctuates based on how the nurses are acting when they come in the room. That determines, what our engagement looks like. That determines what conversations we have while the staff is there versus what we wait to talk about when they leave. All of those things are part of the birth plan, and all of those things fluctuate based on what's happening once we get into the space. And so I just ask them, and I continue to ask, and I continue to check in and make sure that we are on the same page. And sometimes what was a value before those contractions hit changes once we are experiencing those contractions, and I leave room for that as well.
It's hard to follow. That was good. That was all the things. Yeah, I think it's the same, and like everyone has said, it's really about getting to know the folks that you're supporting and that you're serving as people and what their lives look outside of the hospital room and what they really need. And I think it's really important as birth workers that we're really honest with folks around like the ways that our identities and our experiences might align with theirs and the ways that they don't. Someone who has lived experience with drug use, I've never been unhoused and I can't support folks in that. As a white doula, there's like culture and community that I can't meet with folks. And so having really honest conversations like, where are the places I can support you? Where are the places that I can't? And just like you said earlier, who are the partners in our communities that can meet those needs for you? We have some really incredible organizations up in Seattle, Open Arms I mentioned, Hummingbird Indigenous Family Services that can support folks with other needs. And we can partner and really form this partnership around culture and harm reduction and make sure that people's whole needs are met. And something else you said earlier too, is that there is really this, I think if you don't work with folks who use substances, it's easy to overlook that there is a real culture of drug use and there's community in drug use, and especially for folks who are using substances who are unhoused, they have really, really strong networks of community care that keep them alive and help them survive and like build their lives, right? And so understanding those networks is valid, understanding who's a safe provider in that frame is really important as part of getting to know them as well.
So I would say that I oftentimes work with patients who I meet right in the labor and delivery room. Sometimes it's early on in their labor, and sometimes it is not. It is when things have been going on for a while, or even sometimes postpartum. But I would say something that I have really tried to develop from really early on in my career is making sure that the birth room feels like a safe space for that person, okay? And not just for that person, but also for whoever they have decided to be in there. That is their family, that is their community. If I do meet people prior to being in labor and delivery and we're discussing birth plans or discussing who might be in there to support, I tell them, labor and birth, it's not a spectator sport. I want whoever is in there to be somebody who you feel comfortable supporting you. And that might not mean that, they're going to be hands-on. That might not mean that they are even going to be like, up and hand-holding and verbalizing. They might be sleeping. But that's not the point. The point is that the person who is birthing feels comfortable with those people in the room. So I think that part of the ways that I try to incorporate someone's identity, value, culture is literally just letting the room be theirs. My job as a nurse midwife is really to make sure that things are okay, right? I try to make sure that things are safe, that things are, that I can be there to formulate a plan or to help patients, know what is going on. Sometimes things do move quickly, and I want to make sure that they have the information that is appropriate for them to make those decisions for themselves or for their family, for their people, to help them make the decisions that are appropriate for them. I know that there is no way that I'm going to go in and meet somebody and in 10 minutes figure out all the things there is to figure out about them that I need. That's not it. The real place for me is to create that safe room and make sure that I am kind of the keeper of that in terms of nursing as well. As much as I can be, make sure that the nurses that we're working with are also supporting the family, supporting the patient, being respectful, and helping to kind of devise that plan. Okay, so whatever that ends up being, and sometimes that means having people in the room that might not be like the best for you as a care provider. There might be some complications. There might be whatever. It doesn't matter. This is their safe space, and I always want to make sure that we're kind of keeping things how they want it, what is going to be good for them, and talk about it after, talk about things after. If there are things that are, it's just water. If there are things that didn't go well or ways that they might not feel supported in that moment, make sure that we can talk about that and get them that care then,
I don't incorporate anything. I'm not the birthing person. I support. What I think about, I was just sitting here thinking about, is a phrase that I'm going to cling on to for dear life until I stop watching babies come earthside, and that's doulas are, we are like water. We fit into every container in the room. And so that's a quote that Erykah Badu said. And I've held on to that because it's truth. We are just there to support and advocate and move in a way that is best and effective for the people that we're supporting. And so that is where I come from as far as supporting their birth plan, identity, culture, all of those things. I'm actually following their lead. I'm just listening to what it is that they need me to do as far as like support. What way would you like to go with this? I always tell people that I'm supporting that room is theirs for the moment. And they get to run that room. I'm pretty much I'm their employee. That's how I look at it, and I pretty much support. However, I heard Desha, everybody has pretty much said what I would say, but Desha said something about how it changes over time. The document is living and always ever changing, their birth plan. So when I know when I go in with a family that has a birth plan and it's set up, even those, we know who I'm about to talk about, those first time moms that feel like their pregnancy is gonna be perfect and everything is gonna fall into line, because I have this section 1A and we're gonna do this when this happens, right? And then when things go to hell in a handbasket, we are always there to, one, center and bring them back into that space and give them the real options. This is what's going to happen. I always try to do it ahead of time. When I get somebody that's like, oh, I'm going to birth naturally and all these things, and then they say, but I scheduled an induction. You, okay, all right. I got you. I will support pretty much anything, but I always like to let them lead. A lot of times the people that we work with, they lost control over their lives somewhere. And to be able to own that in that space is really important and really dynamic and healing for them, because they get to dictate how this life that they're bringing forth comes forth. And so a lot of times that empowers family, especially in this space of mental health and addiction, when they felt like they didn't have any control and they can have control over this one thing, it may empower them in ways that we would never imagine. So that's how I would support someone's birth plan.
How can providers find and create relationships with culturally specific doulas and midwives in the community? And what are the benefits of connecting people with culturally specific doulas and midwives?
Talk to us. No, I'm just kidding.
Shout it.
Talk to us. Like, talk to each other. I think that's the biggest discount in this community. We will hear something from somebody over here and over there, and we're not talking to each other because that person is not cool. Like, talk to each other. COVID put us in a Zoom room and we never came out. Like, seriously. Put the devices down for a second. Hey, how you doing? And you know what? I do not like eye contact. I will be the first person to tell you. I will look all over here. But when I am making a connection, I look people in their eye. How are you? What's going on? And I don't ask that just so you can tell me, oh, everything. I want to know how you are. I do want to hear what you have to say. We have so many people that are exiting in so many different ways. I don't even get on social media because it seems like it's always somebody dying. And then I won't even get into the rest of it, but talk to each other. And we will make connections. Why is it important? Because if I have a client that is a white cisgender female and she wants the same as far as a doula, I'm not going to be trying to convince her, no, you really should come to my organization because it has all the things. No, I know somebody over here that is perfect for you, right? Talk to each other. Stop walking past people. And that's the honest to God truth. That's where I come from. Like, I'm not an Oregonian. I was born and raised in Kansas, a country girl on a farm, right? I was raised with pigs and cows, and let me tell you something. Sometimes they're a little bit more friendly than you guys. I just got to say that. I would much rather go home to a goat. Like, seriously. Say hello. How are you? What's going on? Like, connect. You know, people do the work that you do. Stop gatekeeping, because that's killing us. Right? Stop gatekeeping. Who are you gatekeeping for? Right? We are women. I'm just speaking to y'all, and we all in the same boat right now. Talk to each other. Stop acting like you are up here and they down here and we over here. We dying, y'all. Stop playing. Hey, how you doing? I got a client over here that was struggling. Hey, I know the perfect connect. That's the only way. We can keep playing this game and acting like, oh, that we didn't connect with them through this, through that. You know that person has that service. Reach out to them. I have Facebook, Instagram. I done messaged people. Hey, I got a client over here that, you know, I don't care. I reach out.
Yeah, I mean, I totally agree. I think I make connections. Also, guys, everybody has hoodies for their organizations. Heck yeah. You know how many times in the community I have seen someone from some doula program and been like, hey, you, let's talk, let's connect. Who are you? Where do you work? What do you do? And I think just in general, making sure that you do have kind of an ear to the ground. I can't say, I mean, I've been working, like you said, with Legacy for many years, for almost a decade now. That doesn't mean that I know everything that's out in the community or everybody that's out in the community. I'd love to learn and to hear from people in other practices who is doing what, you know? And that's true too for birth in general, right? I'm not trying to make revenue off of you having your baby with me. I want you to have your baby in a place that makes you feel safe, supported, and that meets your medical needs, right? If that means that you want a home birth, I am going to help you find that home birth provider that works the best with you, right? And I think that's so important. It isn't about, me winning or me having the most clients or anything like that. This is your experience. Maybe, this is your 5th birth. Maybe this is your first. Maybe, it doesn't matter. I want you to find the place, the experience, the people that are going to help you feel empowered to get through this. And I don't want you to feel like you have to sit here and explain or justify or get me on your level to know what it is that will make that birth experience feel like that for you. So I want you to be able to bring the people in, or to allow us to try to help connect you with people who are going to make that happen. And I think that is so important.
I often get my best recommendations for like safe providers, safe doulas, safe caregivers from folks who are using services themselves. If you ask a person who uses drugs who is a good doctor and who is not, they are gonna tell you. And I think taking that extra step after you've asked your family who their favorite providers are, following up with them after a visit, like was mentioned earlier, to make sure that they still got good care, and then just reaching out to those providers to say, hey, you came highly recommended by the folks that I serve, love to connect with you. I always love when people reach out, and I'm always happy to talk to people. I think specifically for substance use and harm reduction, shout out to needle exchanges. If you don't know where the needle exchange is in your community, Syringe Access Program, the Syringe Services Program here in Portland, you have an amazing program called the Portland People's Outreach Project, PPOP. They will know, again, who is safe in the community for people who use drugs, who can we really trust, who will people go to, and they're a great connection to care for folks.
I think that providers have to see their responsibility, or have to see it as a responsibility, to be knowledgeable about community-based services, whether that's doulas or anything else, the same way we're responsible for being up on any type of medical advancements for the sake of our practices. That is a responsibility for our care. We're past the point of needing to prove the effectiveness of doulas. The evidence is there. We're past the point of needing to prove the effectiveness of culturally responsive care. The evidence is there. And so if you're doing this work at whatever level you're doing this work, whether you're a physician, whether you're a nurse, whether you're a midwife, any type of midwife, there's quite a few different types, whether you're a doula, whatever, however you're serving families, however you're showing up for people, it is your responsibility to be knowledgeable about the connecting services that are available to your families. And there are some hospital systems that have taken it upon themselves to build some of those relationships, but it should not be contingent on the hospital systems. Because changes in leadership, changes in policies, that can easily go away. And we're seeing that obviously federally. It is every provider's responsibility, whether you are in the community or working within a hospital system, to make yourself knowledgeable about how to make sure that your families, your clients, your patients are getting the care that they need.
So I'm going to pause and ask the panel, we have about 15 minutes left. Would you like to give the floor to attendees to ask some Q&A? Yes. All right. Say, raise your hand, and Peter or Jade will come give you a microphone.
Hi, first I wanted to say thank you so much for this panel. This was incredible, and I love each and every one of you. This question is for Telia. When you mentioned trauma-informed furniture, I know that's not about what we just talked about, but I would like a little bit more information on that, please.
You can be any size and fit in my furniture. Yeah, I have plus size clients, and my furniture I had in the beginning, I had one client who has been, I've helped support her with 5 births, and she sat in there in the first, she said, now you know. She was like, this is not gonna work for me, and I'm pretty sure I'm not gonna be the last person, so I got new furniture, needs to say.
This is such a great panel to see. You guys are just the bomb. Okay, my question is, if you have a couple that has a history of criminality, how do you handle it if they're, let me add one more thing, and the mother has a history with CPS or child, you know, that kind of background. How do you, how does that work between mom, you, doula, and their other legal panel that they're working with? You know, if they want to check and see how you doing with this baby. You know, we've taken all your other 5 children. They're in the foster system. So what's going on with this one? How do you guys engage in that situation?
So in those cases, and they happen quite a bit, with families, it's really about, you know, you have your documentation. Just because anytime you're serving somebody, you have your documentation, of course, for how you're providing care. You're serving as you can serve, or you can serve, I should say, as like a character witness, if need be. But also, one of the things that I do is I'm connected and have relationships with some of the services in community that advocate for parents to keep their kids. So even if they've lost custody of other children, or they have open child welfare cases for other children, when we have this new baby come in, sometimes depending on the length of time from the last case, they will do like an immediate check. And so in those cases, immediately reaching out to community for these resources to get this mom connected. These folks already know the child welfare system inside and out. They know all the games that folks play.
Yep.
And they're going to be able to walk this out with them, and I'm going to be able to support them from the doula side, but also from the side as a community advocate. And so I get the professional sort of mentoring from our community experts about what I need to do, how I need to be working with this mom. What some of our conversations, our doula visits are not just going to be like birth focused or postpartum focused. We may be talking about some of the visits that are coming up. We may be talking about court cases and things like that, and how they can better prepare for that stuff as well. And so that's what it looks like to do some of that work. And I think it might have been you earlier that said, like, sometimes our work is not in the scope of being just a doula. And so we spend a whole lot more time with them. My coworker Diane is here. This is some of the work that she does, and she's been one of my mentors in this work too, with dealing with families with child welfare cases. And we spend a whole lot more time with them than you would in a normal doula scope. Mm-hmm. But you get to make sure that a family stays together. And so for me, it's worth it.
I want to chime in from a doula, because Desha came from the doula aspect, but we know that CareOregon and Project Nurture are all doula peers. They're dual certified, right? And so that gives them the capacity to support them in that space as a peer mentor. And so what I will say as a peer mentor, building rapport with DHS should be at the top of your list, especially if you're working with families, going in and speaking with them, connecting with them. In my early stages of doing this work, I actually trained Tri-County DHS. I trained them on how to work with peers and families that were DHS involved. I did that for 3 years, and with that, over time I built rapport. What I found out is a lot of DHS workers are there because they were affected in the same ways, or they had a family, they were connected in some kind of way. So always keep that in mind. You're dealing with another human being, right? Just because they're DHS and they might be a little bit jaded because of their history or their childhood, still come from the lens of them being a human being and trying to connect with them. And that, I'm telling you, that is what really impacts the families that you work with. When they see that they have you as a peer, they already have a good rapport. I've had DHS workers, once people know that people are in my care, they like, just call me when they need something, you know? Because they know that I will stay on top of them. They know that I will support them effectively. They know that I've been doing it for a really long time. So rapport is really important.
Just to add really quickly, I would also just say transparency is incredibly important. I think if I have the honor of seeing people throughout their pregnancy, I try to make sure that we are really open and honest about what their risk factors are, and also tell them that we don't always know what DHS is going to do. There's not like a streamlined A, B, C. So just making sure that they're prepared and that they feel supported, and that as much as possible they feel prepared and not blindsided. So.
I'll add that, I'm a birth worker who works outside of a system. I don't work with a hospital. I'm not certified. And so I think it's very, very important that we have clear and open and transparent conversations with our folks. I will always tell my parents that I work with that CPS will never be the first call I make. It will only be the last call I make. And there are so many steps between meeting a family and understanding their safety concerns before you should make that call to CPS. People should be offered all the other resources in the community that they can before CPS is called. And if you are calling, you should be calling with them. You should be telling them you're calling, and they should be knowing exactly what you're saying to CPS when you're making that report. I think doulas have a really important role to show up in courtrooms, to show up in family team decision meetings, to be advocates for families with CPS. Like I mentioned earlier with clinicians, it's the same thing. The amount of times that I've gotten on an FTDM or a court case and had a nurse or a lawyer say, this mom never even saw her baby in the hospital, she didn't care. She doesn't care. And I was like, that mom had a C-section, was unconscious for 24 hours. There was no opportunity for her to see her baby. This is not negligence. So I think just giving people, like you have such a special role as a birth keeper to see people's whole lives and their whole peoples and their whole stories that is so hard to get across sometimes in CPS and in the courtroom. So bring people's whole stories, advocate for them, and make sure that you stand by their side throughout that process.
And one more question. What of teen mothers, teenage mothers?
Oh, she's right over there.
Sorry, I'm blind. I was like, where is she?
In our program, we have such a wide variety. We have, we have teenagers, we have over 40s, and we just have like such a wide variety. And I think part of the complicated part of it is that we don't have enough volume of just teenagers to be able to have them have their own group or their own program. I do think that would be so invaluable. But we try as a team, we try to recognize that there are different needs that teenagers have, and that there are potentially other teen or young parent specific programs out in the community that we try to join them with. But that can definitely be a complication, but it's just about acknowledging where they are at and what their particular needs are.
I'm not a teenager, obviously. So I always believe supporting teens. We had quite a few come through my org, more than I expected that would. So 2 resources that I always know that have good as far as teen recovery. One, I'll shout out Tony Vazina, 4D. He has an amazing, you just gotta look into the dude. He has a lot of stuff, recovery for young people. Black Parent Initiative, when I started with them at Sacred Roots, they specialize in taking in teens. I don't know how much it's changed, but I do know that there was a structure in place for them to feel supported. It's a little different supporting a teen pregnant person. It's a little different. I will not tell you that it's all, because they're teens. They still know everything. Only thing that they know everything, and they're having a kid now. So, yeah. So I passed. I have a doula in my organization that works really well with teens. She's a younger doula. She's amazing, and I usually refer them to her. Like I said, I will pass someone along. But 4D and BPI in the past for me has been also resources for teens.
Start talking.
So we've got time for one last question, and it's
Yes.
going to be the one right back here.
Hi. God, that's loud. I'm Rachel. I'm here with my team from Volunteers of America, and we have a women's residential treatment center where we have a mix of just female and female identifying folks and folks with babies. So oftentimes we're having women come in with their 2 weeks old straight from the hospital. This is their first time in sobriety in a long time, and they have an infant. And we end up in a situation quite often where there's concern around just some basic parenting skills with some of our moms. And it can create sort of a pressure cooker for the staff, the client, and their peers when there's stress around the safety of the baby or a perception of safety for the baby based on parenting skills or lack thereof. And sometimes it's just basic stuff like cleanliness, diaper changing, how to hold the baby, how to feed the baby, but we are not our staff is not equipped to train them on that. And it's a even harder experience for our moms of color. And so I guess just any advice on being a provider when you can see that someone's just struggling with some of that basic stuff and how to talk to them about it. In the past, I've found that a lot of protectiveness comes up for folks that I got it, it's okay, or no, that never happened. They're getting a lot of judgment, particularly from their peers who've been in the same position as them before. And so how to understand that we really want to make sure that everyone is safe at our treatment center, including the baby, while also holding compassion for how much pressure these folks our moms are under. And just how do you talk to parents when you can just tell that some of the basics aren't quite there? Thanks.
I just want to say a few things before I even say how to talk. Post-acute withdrawal, you throw an infant in there. I've never parented, and I might have some trauma around, and let's not even add postpartum depression and anxiety. You get what I'm saying? That's who you're talking to. So when you feel like you are talking to a brick wall, you most likely are. They have a lot of things going on. So you have to engage them from a space that they can hear you. Even if it's just, hey, I noticed that you're struggling with getting the bottles made, or what is it, how is it that you can feel supported? And maybe you all can't, but her peers can. you know, support them in different ways. That would be a nice time to make community with it. I never really understood why in WRCs and WILPs, they don't have more of a community connection as far as like women that have small children, because we are tribal people. And I don't think people really know that, right? We're tribal. And when we actually tap into who we truly are and we support one another, it wouldn't be so chaotic, right? Women come together in a room with a whole bunch of women, we are powerful. I'm going to toot my own horn, right? So when we are in a group like that and we are struggling in those ways, there's ways that her peers can support her. And it doesn't have to be on staff, but I just want you to think about those things I just listed, right? Throw a baby in there. And if that's not a Molotov cocktail, I don't know what it is, right? Trying to get to know this little human that does not pay any bills and demands breast milk all the time. Right. Right. Katie said has no back strength. You got to hold them up. They talk stuff like, yeah. Anyway, just think about it from that. And maybe then on your end of it, the empathy and the compassion, the understanding, because we do get overwhelmed and frustrated as practitioners and providers, and we wonder why they can't get it, right? If you would just listen to this, and a lot of times they have such their internal narrative, they cannot hear you. They have a lot of stuff going on. So whatever they connect with on the outside, you connect with that too. You see that they like color. I used to bring one of my clients coloring books, just to get her to sit down and talk to me about what was going on, right? Sometimes you have to get on their level.
And, you know, if at all possible, I would say parent mentors, you know, absolutely. Yeah, I think that it is really complicated when you're trying to, postpartum doulas. 100%, absolutely, which I think is kind of in that same idea, right? Parent mentors. I think instead of the idea of telling somebody how to do it, build from the ground up, you know? And I think that we are, I think that we often forget or just, I don't know, there's an assumption that everybody knows certain things, right? But I have to say, having done this job, you know, there's a lot of missing information. We are not taught a lot about our bodies. That's just how our school system is. We are not taught a lot about bodies. We are not taught a lot about, you know, how to hold a baby, or, you know, there are childbirth education classes, but when you have a million other things going on, or you're not sure if you're going to parent, or you're pretending like there isn't a baby because you have a lot of trauma going on, or, you know, whatever. Or maybe you have gone through, maybe you have had 5 babies and, you know, have not had the experience that is the one that you want now. You know, you can't make assumptions that anybody knows anything. And so I think it's really important, again, to build from the bottom up and not assume that people have seen how to effectively parent from their parents or from family members or from friends. That might not be part of their community. They may have never witnessed that. And, you know, and then we're kind of throwing on top of it, here you go, you know, here's a baby, figure it out. You know, in the hospital, we teach them how to change diapers and make a bottle and, you know, and swaddle, and there you go. But, you know, from my own experience, somebody who is well-resourced, who is really knowledgeable about, you know, about bodies, about postpartum, about all those things, I was a freaking mess. I have never felt so terrible about everything, and that nothing was in my brain for a very long time. And even though I have worked with this population for, you know, for many years, that experience made me feel like opened my eyes even more to the fact that, oh my God, people feel like absolute crap. They're going through withdrawal, or they're going through trauma, or they are re-traumatized by DHS coming in. There are so many reasons. And we have some people who have been houseless for a decade, you know, and now we're saying live in these walls and live with rules and parent this baby. you know. And so I think just realizing the complexities and the lack of support, and that's not to say that you guys are not supportive, but just we really don't have that, you know, here's a mom or auntie to just like teach you how to do these things and hold your baby and hold you when you are, you know, crying. And so I do think that like postpartum doulas, amazing, you know, and if we can get more, let's do it.
I would just add, I know that everybody is like under-resourced, but if you know that your organization is going to be serving people who have given birth, it would be worth it to invest in having a couple of your staff trained in childbirth education, newborn care, those types of things, so that they can be integrated in how you all support your clients. Just, you know, look for some money, I don't know. But, and that's easier said than done for sure. But if you know that this is the population that you're serving, it would be worth it to invest in your staff this way, invest in your team this way, so that you do have staff who have that knowledge on hand, who are knowledgeable about popular education models and things of that nature, just to be able to add an additional support. And in addition to being able to bring in postpartum doulas, but we know that your staff are typically there even when a doula will not be, and just to be prepared to answer questions or to address something that may need to be addressed in the moment for the sake of safety. And even if they can't be formally trained, I think that there are several, and I'm saying I think, but I know that there are several organizations in the community that offer those classes. And if you were to reach out to an organization and say, hey, we can't afford to pay for our staff to be trained, but we need them to be knowledgeable for the sake of better serving our families, I'm sure someone would let you shadow their classes and allow you guys to hear the material and hear the education, so that you guys have some of that information to take it back to better serve the clients that you guys are supporting.
All right, we are going to take a quick break before our next session. I know that lots of you have lots of questions. Definitely keep the conversations going, but as we break before our next session, give our panelists a round of applause. That was amazing.